in glioblastoma or GBM, there are three main reasons we think that EGFR inhibitors have failed in the past and that we've addressed with the 1535 development program. First is tumor heterogeneity. Second is the lack of adequate brain penetration. And third was the reversible binding mode that some of those past inhibitors had. So first of all, glioblastoma tumors are heterogeneous. So that means that there's often multiple oncogenic drivers within even the same tumor. 1535 has potent anti-proliferative activity against a very broad set of EGFR extracellular domain alterations that are typically associated with GBM, including the prevalent variants that many people know about, the variant 3 and also variant 6. We have an average IC50 of below 4 nanomolar. Also, EGFR amplification often precedes and co-occurs with EGFR mutations and splice variants in GBM. 1535 is able to inhibit EGFR in the amplified setting. But importantly, it retains an average almost 60-fold selectivity over wild-type EGFR that is expressed under normal conditions. And it's that we believe will increase the therapeutic index in the GBM setting. So the second thing I mentioned was brain penetration. So obviously to address GBM, it's absolutely essential that you can reach the CNS. Our in vivo PK profiling of penetration of CNS showed that 1535 compares really very favorably to all of the approved EGFR inhibitors. So it has a KPUU of about 0.5 in rat. The approved first generation EGFR inhibitors, so erlotinib and gefitinib, as well as the approved second generation inhibitors, afatinib and dacomitinib, all show much lower KPUU values in rats. And so they wouldn't be expected to deliver the high levels of free drug that you're going to need to the CNS to treat glioblastoma. The third generation inhibitor, osimertinib, that is regarded as being very good brain penetrant EGFR inhibitor, that actually has a measured KPUU of 0.2. So we compare very favorably to that as well. And so we would anticipate that the higher concentrations of unbound BDTX-1535 that we can achieve will reach the CNS and will therefore lead to regressions, as we noted in our intracranial mouse models of GBM. And then last of all, the third important piece is irreversible binding. So we think irreversible binding is an essential characteristic for effective inhibition of the EGFR mutations and splice variants in GBM. So without it, the ability to adequately address GBM will be very limited. So in the clinic, reversible EGFR inhibitors like erlotinib led to very significant improvement in progression-free survival in patients with EGFR kinase domain mutant-driven non-small cell lung cancer. But no survival improvement was observed when erlotinib was studied in GBM patients expressing EGFR extracellular domain mutations. Those are the ones associated with GBM. So our Black Diamond research team determined that a common feature of the extracellular domain mutations associated with GBM is actually an increase in the number of free cysteine residues at the interface of the active EGFR dimer. And in the GBM-altered mutants, binding of reversible inhibitors to the monomeric form of EGFR brings those free cysteines from each monomer into close proximity, and that promotes the formation of covalent disulfide bonds and locks the dimer in the active form. And so the outcome of that is that at lower concentrations, reversible inhibitors can actually be released. They leave the active EGFR dimer behind. And so they can inhibit kinase domain mutations associated with lung cancer, they actually can cause paradoxical activation of signaling in the cells expressing these extracellular domain mutations that cause GBM. And they actually cause they do cause an initial reduction in phosphorylation of EGFR. They then can cause activation and enhanced phosphorylation above that of control as the compound is cleared from the system.